We'll be starting the pediatrics meeting in about 1 minute.
We decided to come around here with y'all.
Remember he bought the Mustang and started buying all those expensive things like that? That was his extra treated to be.
He fell down to the class. He fell out of the class.
He had the Filipino
See, right there in that corner.
Yep. He had glasses.
They need to make the clock better and make it like a basketball air horn.
When it hits zero, like a red light needs to
We are
circle us.
waiting. We
Like a real shot clock.
4, 5, 6, 7, and yes, we do. We're just waiting for Diana to come back in.
Yep.
It was in June.
There she is.
Almost today.
All right, can we please ask that you take your seats? Are we ready with the timer? Great, thank you. So this is the Pediatric Subcommittee. My name's Charles Macias. I chair the subcommittee, and I'm calling this meeting to order. A little bit late, but we will move rapidly through our agenda items. So as always, we start with our roll call. Britt DeVilliers, I know, is not here. Justin Hensley. And Bonnie Hartstein could not be here. Charles Jaquith.
Here.
Juan Juarez.
Here.
Diana Kraus. Julie Lewis. Jorge Sainz.
Here.
Sally Snow.
Yes, sir.
And Vern Walker.
Here.
So we have 3 absent. That means we have a quorum. Excellent. All right, so we start with our committee liaison reports. Air Medical, Jorge?
Charles, they still have a discussion about the Washington trauma guidelines, for pediatrics. It will continue today. They were sent out for review, and so the meeting will take place today. So I'll send you an email back. But there is pediatric specific, assessment topics, that are for the Washington trauma guidelines for transfer, interfacility transfers.
Okay, perfect. Thank you. EMS, Vern?
The EMS committee will meet tomorrow at, I believe, 2 o'clock. I'll attend that. I don't remember off the top of my head any specific pediatric issues from the
Prior meeting. Okay. All right, education, Charles?
They had a meeting between our last meeting here in Austin. They're starting to look into the community paramedics. And at this point, it's just getting started, but as you get down the road, you'll see involvement with several of the committees here, to include the pediatric side.
Okay. And I'm sorry, is there a meeting?
Their meeting
To their
is tomorrow at 9 o'clock. I believe it is.
Okay. So we've got some potential pediatric issues there. Injury prevention, Diana?
Injury prevention meets at 1 o'clock this afternoon.
Are you aware of any pediatric issues from the last meeting that would translate into this meeting?
Not that I'm aware of.
Okay. Medical directors.
They will be meeting tomorrow as well, and I'll be attending and forward you an update.
Okay. Any potential pediatric issues you're aware of?
Not in the last meeting.
Okay. Stroke? Oh, that's Julie's. So we will, and from her last discussion, there was not any pediatric issues she was concerned with. Trauma Systems, Sally.
Trauma Systems meets tomorrow at 10:30. I'll be there for that, and I'm not aware of any pediatric issues. I believe I reported last time we met on the committee's actions last
You did,
month. Yeah.
and that's in the minutes. The RACs,
They meet tonight after they're about 5:30, and I'm gonna sit in and pray.
okay. Charles. And disaster planning. I think we have moved the discussion of STEER into its own agenda item. Is that correct, Diane? I think you're reporting for you and Bonnie?
Yes.
Perfect. So I'm going to take that off of the liaison report and put that into the actual agenda. All right. Susan Rodriguez, are you here today? Okay. I don't have any updates then. As members of the committee remember, we have a standing agenda item to hear updates on the child fatality review teams. I think their biggest activity occurred and was reported on 2 meetings ago, which was their report and addition of 2 additional members on the Child Fatality Review State Committee. So nothing new to report there. And our next agenda item is the position paper on minimizing CT radiation. We had 3 discussions to frame quality improvement implementation recommendations, rule revisions, governing radiation exposure, and the development of a framework for external links to pediatric radiation exposure. One particular item that we had discussed with quality improvement strategies was reaching out to other organizations. Over the course of the last 2 meetings, we've discussed, members of the committee have brought discussion for a framework of other organizations. I will tell you that that list currently consists of professional societies, but there was a specific charge with what we need to look at in particular for both rules changes and possible electronic linkages, and that was Juan Juarez and Jorge that were going to report on that.
And in direct link to the what we have on the DSHS site. Currently, what they hold on the radiation control program site under the CT subheading, there are links out to the Alliance for Radiation Safety and Pediatric Imaging, the American Association of Physicists in Medicine, American College of Radiology, and Conference of Radiation Control Program Directors. These were added there over a period of time, I believe, since 2010, which was their last major discussion on the decrease of radiation dosing for ionizing features for pediatrics. So those sites are currently available now.
Okay, can you forward those so that I can add those to the minutes?
I'll forward
Perfect.
those to you.
Thank you. In terms of needed links,
We discussed that at the last meeting. I brought up some of the key links that we should approach them. I'm still waiting to hear back from them in
Perfect.
terms of how that can be implemented, or if it might at all. So I'll get back to you during the intro. I'll forward you.
okay.
Charles, do you think it will be of any value to think about to try to set up the ability for all organizations that are exposing children to radiation, either by a CT, regular X-ray, or fluoroscopy, to keep a tally of the radiation exposure based on medical record? You know, that's actually something that we're doing in our hospital already. So you come in, you know, you get a CT, it assigns you the amount of level of radiation that you got and goes into your jacket. And, you know, we don't have a specific trigger of what to do with that information, but we know exactly how much radiation all children have gotten. Now, if there's a problem with the medical records, then there's a problem with following that. But you know, if we're concerned about, you know, the level of exposure, you know, we really don't have the first step to actually try to monitor how are we doing. You know, we agree that, you know, we have the recommendations as far as, you know, following pediatric-specific protocols and so far and so on, try to minimize that. But as far as moving forward to try to set up something to actually monitor the level of radiation that they're getting exposed.
And what you described as quality improvement strategies, and one of the things that we talked about in prior meetings was how do we, within the committee, help disseminate the conceptual models that are out there for quality improvement, one of which is one that you described. And I think that may be the value of some of these linkages. I think the problem is that there's not an existing organization that really is housing these best practice strategies. And not sure where the right place is for that, or how we reach out to an organization to say this is something you should be linking. Is this potentially something that the TPS committee could be doing? Could we request some partnership there?
And just as a reminder, I believe I brought that piece up in the previous meetings. The problem with that is that it's a local institution, hospital level decision on whether that information is portrayed in a medical record. There's nothing on a state level. Some places out in California instituted those policies and plans, but that governed a small portion. It wasn't a uniformed direction for the state.
Exactly. So we agree with that same feeling. But if we're trying to create quality measure strategies, will that be something that we should potentially look into it and to try to standardize throughout the state?
Well, I think that that's really about resources that are available and what strategies are going to work in different areas, and that certainly could be one of them. I think the bigger issue there is if this is a discussion about standardization, then up until 2017, which is the target date for the current rules revision, centering around radiation, we need to decide when the right time and what the right recommendations for rules revisions are. So we have about a year to do that. The question is at what point and how do we formalize that process? I think the two of you have sort of become our local experts at this, so we look to your guidance to when we want to move those rules recommendations from here to the council for formal approval. So I will keep that on the agenda item, as an agenda item for the next meeting as well, if you want to explore a little bit more on the existing rules and what opportunities there are to standardize best practices.
Dr. Macias, can you make sure your committee uses the microphones? It's very difficult to hear that entire discussion.
Okay. All right. So do you need a recap of that discussion?
A recap would be great.
Okay, so the recap to the discussion is that there were really two critical elements related to minimizing ionizing radiation in the position paper that we'd established for, and that was endorsed by the council. This was really focused on reducing ionizing radiation specifically from CTs. The particular reason that the pediatric population is at risk, of course, is correlational data that suggests that there are about 500 cases of childhood cancer deaths resulting from about 600,000 CTs. So when you consider the sheer number of CTs obtained in pediatrics and children, and consider some of the strategies that people use, for example, for managing trauma, which is pretty much head to toe CT ionizing radiation, this became a pertinent issue. What we have adopted over time was we're distilling this down to quality improvement approaches to support for more enhanced links that are virtual in nature, of course, but linked to the state's radiation site. And then the third was recognition that there really aren't many regulations in this particular state for what has to be, for what kind of pediatric protocols need to be utilized, et cetera. But there is opportunity and there is precedent. Our last discussion, we learned that there's rules revisions that are that could be submitted, but would be considered in 2017. So this committee decided that we would take that opportunity to make some recommendations for what we think would be valuable. The reason that it's so important in this group versus the adult group is that the issues of childhood cancer deaths and the damage from those are far more pertinent to the pediatric population than they are to the adult population. So that's sort of the discussion in a nutshell. What we said we would do for moving forward is we'll wait from our 2 local experts who have become local experts at this outreach to hear back from where future links can be placed to provide more quality improvement best practices. And we're also hear back from them regarding what the rules revisions might look like and when is the right time to submit them to the council.
Thank you.
No problem. All right, so moving forward, we have injury prevention and head injury presentation within arm's reach. Connie Manley, are you here?
I'm here. See if I can get this going. I don't know the password. Maybe we'll get it. Do you know?
That's really what, yeah.
Okay. I'm gonna have trouble here.
Should we move on to another agenda item, or
I'm
are you
ready.
ready? Okay.
Thank you for the opportunity to talk with your committee about my project. My name is Connie Manley. I'm the Trauma Program Manager at Valley Regional Medical Center. We're a Level 3 trauma facility in Brownsville, Texas, and we sit just a few miles from the border. I've been there, I'm starting on my 5th year. Once I started there, I approached my CNO, Holly Tyler, and I said, I've really identified a serious situation that I'm not sure how to handle. We just have an ungodly amount of pediatric head injuries as a result of falls. So I began collecting the data. The hospital mission. In 18 months, we collected data on over 1,000 children that had fallen and were diagnosed with head injuries. We had exclusion and inclusion criteria. We picked 17-year-olds, and we picked injuries as a result of falls that only involved head and face injuries. We took out all the broken arms and the broken legs, and we specifically put our energy into head injuries and how we were managing these situations. We discovered that almost 75% of our injuries were in the age group of under 5 years of age. We categorized them between 1 and 5, 6 and 10, and 11 and 17. And then we began to look at how we manage these patients. Of the 721 patients in this category, 227 of them received CT head scans. We went back and looked to make sure that we had done all the appropriate adjustments, and each and every one of them had the appropriate adjustments for the radiation exposure. We discovered in this age group that most of these children are falling from shopping carts, and they're falling from within the baskets of shopping carts. They're falling from sofas and cribs. They're falling from adult beds. But what we continued to hear over and over and over again were the care providers saying, I just stepped away for a moment, or I was distracted, or I was just detained for a moment. So we began to think how we could address this. The other age groups, smaller age groups, so we put our attention on the age group of 5 and under. In this age group, we discovered they were falling from playground equipment and bicycles, ladders and chairs, and freestanding structures. The older age group, they basically were sporting events and being pushed and shoved and falling from standing position. We already know the risk and hazards of radiation exposure. We've just finished a conversation about that, so I'm going to just pass through this information. We know the risk of children exposed, so we decided what are we going to do with this information now that we have it. We're going to do everything we can to eliminate the injury in the beginning. So Valley Regional, we decided to take on this concept and develop a program. We formed a multidisciplinary team, and that team consists of our trauma doctors, our radiologists, our directors, and our administrative leadership. We all sat down and I said, this is the information we have, this is the program I want to present, so let's all put our heads together. We discovered a couple of things. One is the key point that most of the patients were left unattended or the parents were distracted. The other thing that we were surprised to find is a lot of our patients are showing up after they've been seen by their primary care provider and sent to our emergency department asking for a head CT scan. So it kind of put our ER doctors in a position, a debate with our patients, caregivers, on how to manage those situations. So we developed a campaign that we call WAR. The acronym stands for Within Arm's Reach. We're hoping that simple concept is going to have enough teeth to really make an impact on our public. We are going to launch this. Hopefully this is going to be something we can launch very wide in our community and will have an impact. We're going to start by educating our staff, and we're going to have those conversations. I'm already have talked a lot with the emergency department directors and the doctors in the emergency department. And I'm already beginning to see some documentation of very detailed conversations that they're beginning to have with the parents. So I had not seen that before. So this program already is starting to have a little bit of influence on what's going on. I'm seeing that there are more time put into the decision making as far as, do we really need a CT head, or can we observe this patient and make a decision down the road? Is this something that could do without the radiation exposure? So I'm really proud that the emergency department has taken a stand and partnered with us and already starting to implement some parts of this program. The PCARM we added to the doctors' computers in the emergency department just to give them a resource to help guide in some of the decision making. We're going to continue to monitor the outcomes, and we're going to continue to monitor the exposure to the children. So our program Within Arm's Reach is the key concept of what we hope to educate our public about. This is this picture is the absolute essence of what our program is about. We feel that our children are extremely fragile, and once broken, they're not recyclable. So we're going to use that concept to try to teach our public how important it is to do the right thing and stand up and speak for those children that can't speak for themselves. So this slide is just safety measures that I'm hoping everyone in this room already knows, and that is on the flyers that I've put on your table. This is information we're hoping to drive home with our program. But the very first one you see is be within arm's reach of your child. So I'm going to ask each and every person in this room to take this concept back to your facilities and try to start having the types of conversations that can make a difference in eliminating this injury. Our key concept in this program is to be within arm's reach of your child. I personally am involved in this because I have 4 grandchildren, and I've asked the mother, I've had 2 grandchildren fall, and I asked the mother each time, could this have been avoided if you were within arm's reach? And they said absolutely. Absolutely it could have been. Again, the WAR also is, a program that's going to teach to eliminate distractions. The reason I like this program so much, and I've had so much support from my facility, my leadership, and my corporation, and my RACV, is because this is a simple concept that can be remembered by everyone. I always say my husband, who is not medical in any manner whatsoever, he's totally business. He understands this concept because it's easy to remember. So what I hope that you take away from this is to go back to your facilities and take a really hard look at how we're treating our pediatric patients. And can we do better? I'm one little speck on the huge Texas map. I'm way down there in the very little bitty bottom, and if I'm seeing 1,000 patients, I'm concerned about how many patients statewide that we're dealing with. I'm also asking that you take away the concept that our children are fragile and they're not recyclable, and they're asking us to speak up for them and to do the right thing and do what we can to prevent this injury. Is this the answer to all of this? I don't know. But this is a program that I have strong support from my facility and strong support from my administrative leadership, and we're hoping it's got a concept that our public can be aware of. That's my presentation. Does anyone have any questions?
Questions from the committee?
I do. So you gave us this great brochure.
Thank you.
can we steal it? Can we
Yes,
take
ma'am.
it out?
It's a program. This, to me, pediatric head trauma is not about Valley Regional Medical Center. It's about each and every person in healthcare. This is an opportunity to make an impact. I'm hoping this program is strong enough that everyone here can take it back. I am willing to come and teach this to anyone who would invite me. I think it's a simple concept, but I think it's rememberable, and I think it will have a place.
Well, I think every single one of us could go back and duplicate your,
Absolutely.
you know, your efforts at looking at what your incidents are. And I really, really like your safety measure stuff. So hopefully we can get this out to all the hospitals, and you know, through this committee and through the Injury Prevention Committee, and actually every committee of GETAC would benefit from it.
I would really love very much for Texas to be the lead in such an injury prevention program. I think it's something that's going to have just enough teeth that the public it's simple and the public can understand it.
Okay, great job, thanks.
Any other questions?
So a couple questions.
Yes.
So the populations that you looked at, one of the issues that we've addressed with CT utilization and what we described in our position paper was the transferred in population. And
We are level 3, and I'm going on my 5th year, and in 5 years we've never had a transfer in. The majority of our patients we transfer to higher level care. We'll either manage them there or transfer to higher level care. Out of this group of 1,000 patients, we had 10 patients that we transferred out with intracranial bleeds.
okay. And then just a couple of thoughts. One is that this is one of those types of best practice quality improvement projects that we were describing in the previous discussion. It'd be great if you could send us sort of along with your slide deck just a little one-page description or half page.
I actually have an article that I have written, and my leadership helped me prepare, and we sat down and did it as in our multidisciplinary. I'd be happy to send that to you.
Yeah, if you could do that, then we will, in whatever we're able to figure out is going to be our housing, our best strategies, QI projects, we can certainly do that. The other thing that I would ask you to do, because so much of quality improvement is embedded in transparency of data and looking at outcomes,
Yes.
is to report back in a year what your
Absolutely.
outcomes have been.
We are continuing to gather that data. We decided we were going to make an effort to saturate the public in about a 3-month period and then take a strong look at the data. But as I said, I'm already beginning to see some those detailed conversations that our ER doctors didn't have before. I'm actually seeing CT scans being chosen not to be done on patients that normally would have been done in the past. So if we could do better as a little teeny tiny hospital, we can all do better as a state.
Oh, I agree. No, this is wonderful and clearly parallels what we have previously described. My last question to you is, I'm assuming that you have reached out to EMSC and to the state partnership, and there's ability to
I've been on the
cross.
phone with Sam Vance constantly.
Okay, perfect. So
Yes, I
you
have.
certainly have a place there. Perfect.
Yes.
All right.
Any
Well,
other questions?
thank
Anything
you.
else I can shed light on?
Yes.
Thank you so much for the
Hold on, I have
opportunity.
one
to
question.
present. Oh, I'm sorry, yes.
So it looks like you have two primary outcomes. One is to decrease the incidence of these mild traumatic brain injuries or
Yes.
head traumas for those respective age groups. And then 2 is to improve the overall care by risk stratification using
Yes.
the PCARN data, correct?
Yes.
Those are your two primary outcomes. How do you, from the kind of CT utilization, how do you, besides the education for the ED providers, how do you impart those decision supports besides just having the information available? Or is it built into your electronic system?
We realized that, first of all, the children and parents that are showing up saying, well, we just came from our doctor's office and they told us to come here and get a head CT. Now, we've had children that fell 3 and 4 days prior that are showing up requesting this because their primary doctor said it was really important in diagnosis. We're picking up on that, and we've decided we need to strongly educate our medical staff, that's partners of our facility, and the public as well. So I think that will make a small dent in what we're doing. But we're hoping by making a huge dent on the injury concept itself will decrease our radiation need in our emergency department, as well as those patients who come in that normally we would just get a CT scan because they fell and bumped their head, now we're beginning to look at the signs and symptoms and the possibility of just watching this patient in the emergency department, observing them and trying to make a more diligent decision on whether these patients need CT scans or not. So we're hoping that the prevention is going to have a huge impact on the need for radiation.
Of course. And in terms of how you approach the education, is it strictly the ED providers and that in the environment in the ED, or did you reach out to radiology?
Yes, radiology actually has been involved in this program from the beginning. Our radiologist is one of the first persons that I went to and said, you know, here's what we have, and these are, as I told him, these are our future leaders and doctors and nurses and astronauts and presidents, and we don't want to make them sick. And he agreed, and he's like, well, let me take a look at this. So he actually studied the concept for about 2 weeks, and he came back to me and he said, this is what we liked. He looked at the PCAR, and he liked the resources there as well. He also looked and he says, we're going to be really diligent about making sure that we've adjusted the radiation. And we had done that, but we're going to continue to monitor the fact that we're doing CT scans on some patients, and we're going to continue to monitor that adjustment. As well as we're going to have the biggest impact in the prevention of the injury. And he agreed with that. He felt like the energy that we need to put into this program is prevention.
Thank you. One last question. Have you considered translating this into a different language, Spanish,
Yes,
probably
sir,
for you, or any other languages
Exactly.
as it disseminates through the state,
Yes,
depending on where it's going to be at?
I'm sorry. Yes, I have them both in English and Spanish, and we did that because my population is 97% Hispanic. So I have just as many in Spanish. Other languages, no, I have not. If I see the need for that, by all means, that's something. My hospital's been 100% supportive of this program, and if there is a need there, by all means, we will certainly address it.
I think maybe as it disseminates through the whole state, that might be that need arise,
Yes.
in the future,
Yes.
as far as you translate it to other languages.
Absolutely.
Great. Thank you so much.
Thank you very much.
All right, our next. Our next agenda item is EMS for Children's State Partnership update. Sam?
Good morning. Hello, can you all
Morning.
hear me? Okay, I'll just bend down a little. So as y'all are aware, we have been instigating a program for pediatric facility categorization or recognition. We held a webinar on April 17th and April 28th to disseminate that information. We had about 135 people participate in those webinars over that 2-day period, including trauma managers, ER managers, a couple CEOs, folks from DSHS, and legislative folks from Health and Human Services.
Can I stop you for 1 second? Has everybody here had the opportunity to see that webinar?
Yep.
Okay.
Yes? Okay. Thank you. Go ahead.
Yeah, I just wanted to give you a brief update on that if you have not had the opportunity to see the webinar, I did email that link out a couple weeks ago. Probably just about everybody in this room has received it. If not, the link is available on our website for you to view that recorded webinar. And just to give you an update as far as where we're at, we have received formal endorsement for the program from the Texas Pediatric Society as well as the Texas Emergency Nurses Association. Are there any questions on that? Okay. Similarly, we are working on a voluntary pediatric recognition program for EMS, which I will probably go into a little more detail in the EMS committee tomorrow. But basically what that covers is that it will recognize an EMS agency for having the pediatric equipment that's on the National Pediatric Equipment List, as well as pediatric protocols. It will also recognize them for pediatric continuing education and community outreach. And like I said, I'll probably go into a little more detail on that in the EMS committee tomorrow, just for sake of time. As most of you are aware, next week is EMS week. Yeah, it's already upon us. And this year, it does mark the 30th anniversary of the National EMS for Children program. And we have done a few things to help celebrate that. The first one is we had a contest to draw the EMS for Children program here in Texas a new logo. The winner of that logo contest was, her name is Reagan Olson. She is from Hunt County EMS up in Greenville. And so next Monday evening at 6:30, we'll be presenting her with her award, and that's when we will officially unveil the new logo. So sorry you don't get to see it yet. Anyway, so they are making a big community event in addition to this, that for kids, they're actually going to have the Dallas Mavericks cheerleaders and the Dallas Mavericks mascot there, as well as the Dallas Mavericks are providing a DJ for the event. So that's pretty cool. That right there is good enough reason for me to go. Anyway, as y'all know, the Wednesday of EMS week is always EMS for Children Day. We have received a proclamation from the governor that May 21st is EMS for Children Day in Texas. We will be presenting that proclamation on the south steps of the state capitol at 10:30 a.m. Everyone is welcome to come. Unfortunately, the governor is not able to make it, but we are hoping to have State Senator Charles Schwertner there to present the proclamation. Then finally, on Friday, May 23rd, every year we recognize a crew of the year for EMS Children Crew of the Year that had an outstanding call with pediatrics, or they're doing something outstanding in pediatric community outreach. This year, the Crew of the Year award goes to members of the Marble Falls EMS and Horseshoe Bay Fire Department. And we will be presenting that award at 10 o'clock on Friday, May 23rd in Horseshoe Bay, Texas. So, that's all I have for you. Y'all have any questions?
Not a question, just a comment. Because we are partnering with this pediatric facility recognition program, we are moving that agenda item as a full committee agenda item for future agendas. So we'll have that, if you can help inform this group so that we can address it more fully. Thank you.
Sure, and if you would like me to come and speak to the committees specifically, I'd be more than happy to do it.
Great, thank you.
All right, thanks.
Anything for Sam? No? All right. Our next agenda item is Sally, update on pediatric transfer guidelines and review Washington State pediatric consultation.
I am pleased to thank my committee, Mitch Morber from Abilene, Justin Boyd from Amarillo, Deb Boudreau from Fort Worth, Sarah Safrant from Harlingen, Christine Reeve from Waco, and Julie Lewis. And Julie's from Austin? Temple? Somebody help me. Where's Julie from? Nobody knows where Julie lives. Anyway, we have a draft. Dr. Remick and I used the Washington State Transfer Guideline as our template and have drafted our first draft for Texas. It has been sent out to the task force. I've received a couple of comments back from them. Our plan is to get back all of our task force comments and make whatever revisions are necessary, and then bring that draft to the GETAC Pediatric Committee, get some input, and hopefully have a draft for approval by this committee by our August meeting, and then hopefully be able to disseminate that draft to other GETAC committees for final approval, hopefully by the end of the year.
Where is the public vetting in that process?
Oh, what a good question. I would assume that we'll certainly hear public comment at the GETAC committees, and I don't know what is the mechanism for just general public comment. Is there, like, could we put it on the GETAC website?
Well, it goes on the GETAC
Does it go on the
website.
GETAC
Once
website?
once the template gets submitted with our agenda, then
Mhm.
it can be on the website. So certainly everyone here will know that, but we can. But then anybody who accesses
Right.
the website will know that as well.
Okay, okay. So
Perfect.
there's the mechanism for public
Okay.
comment.
Just want to make sure.
That's it.
Comments for Sally? Okay. Thank you. That is a task that has been on our to-do list for, I don't know, 3 years, Sally?
Well, we don't get in any hurry around here.
No, it's quite an endeavor. Thank you for taking that on. All right. Our next agenda item is update on Model EMS clinical guidelines. Sam, you are standing in for Dr. Shaw.
Yes, I am. He was unable to be here today, so he asked me to fill in for him. So the National Association of State EMS Officials have been working on Model EMS guidelines. They recently put out their final draft for stakeholder feedback, and that feedback is now closed. The work group is currently in the process of revising the document from those guidelines, on the guidelines based on that feedback, and a final document will be released in the fall, which will include guidelines for 40 common conditions. The guidelines are meant to be a minimum set of recommendations for medical directors to create protocols for their service. Evidence-based guidelines that are developed are going to be incorporated into this document. Do I have any questions about the Model EMS guidelines? The next item that Dr. Shaw had to present to you was the Pediatric Evidence-Based Guidelines Assessment of EMS Utilization in States, or PEGASUS. This is from a targeted issues grant that he received for creating evidence-based guidelines. And the 4 evidence-based guidelines they're working on right now are for spinal immobilization, shock, airway management, and allergic reaction. They also put this final draft out for feedback from stakeholders, and that feedback closed on May the 11th. The work group is going to be meeting next week to make final revisions, and the protocols will be implemented in Houston Fire Department in the fall, and they will be followed by the 6 New England states in the spring. And these guidelines will be written for publication and will be published hopefully by early 2015. The main recommendations from these guidelines are being incorporated into the NASIMSO Model EMS guidelines.
A couple things. Just I missed spinal. I should know the spinal immobilization, shock, anaphylaxis. What was the fourth?
Airway management. Airway management. Yes. Sorry for going a little fast.
And you said allergic reaction, but it is anaphylaxis, correct?
Anaphylaxis.
It's both. Okay. It's both, actually.
It's both?
It has both arms on it.
Okay. Any questions for Sam?
All right. Thank you.
Great, thank you. All right, next agenda item is update on State of Texas Emergency Assistance Registry. Bonnie and Diana.
We have nothing to update. She didn't give me anything to update, so
Okay.
I apologize.
She actually sent something to me, and I can't access it right now, so we'll just put it on the August agenda.
Yes.
Thank you. Sorry about that. For some reason, I can't get into the system. Update on complex care registry. That's part of that as well. So that's also tabled. Sally, agenda item number 11, consider quality performance metrics for the improvement of care of children in emergent and urgent care settings. This was intended to open a discussion for what we are doing in this state to define meaningful metrics at the provider level for pre-hospital and emergent care, urgent care hospital settings.
And thank you for reminding me what that discussion was about, Dr. Macias, because I was going to be looking like a deer in headlights right now going, I don't know what you're talking about. So we had this discussion a couple of days ago, and I visited with the National ENA president who sits on the Emergency Department Benchmarking Alliance, and she tells me that that group has decided not to do specific pediatric metrics, but she did guide me over to PCARN, who has a few metrics. Apparently, Children's Hospital Association has some e-metrics for children for emergency, and EMSC is in the process of revising their performance measures, which may include some metrics, but that revision may not take place until as late as 2017. And we also talked a little bit about NQF, and understand that NQF has not ever adopted the pediatric weights in kilograms as a metric because there was no evidence to back up that claim. We are concerned that we might be able to use a position statement that was endorsed by many, many professional organizations as a standard. Hopefully we'll be able to go back, or someone, I think, will go back to NQF and request that as a metric again in the near future. So I need to look more into the PCARN and the CHA emergency metrics, and then maybe bring some more information back at some point.
Okay. So the PCARN metrics, which were part of the EMSC scorecard for pediatric ED-based settings, or ED-based settings that saw pediatric patients, were isolated to only hospital-based.
Mm-hmm.
There are 60-plus metrics with a short scorecard of over 15. The short scorecard I know have undergone a vetting process that included Joint Commission, et cetera, and so anything revised has been there, and that was fairly recent. So I think that's where those reside. I think it might be helpful for us to actually look at that brief scorecard at our next meeting and decide where we want to take this initiative. I think part of the challenge with having gaps in quality of outcomes is that there's a wide variability in what people consider to be performance metrics, and I do think that it's within our realm to decide upon what we view as meaningful metrics for evaluation of pediatric ER settings, and so maybe aggregating these and looking at and posting those prior to our next meeting, having members of the committee actually look at the metrics, and then decide what next steps should be based upon that. I think that would be helpful. One other thing I can tell you from my personal experiences with the National Quality Forum was that one of the committees of the American Academy of Pediatrics Committee on Quality Transformation gathered a group of about 13 hospitals to provide validity and reliability testing on weight in kilos. And so there is data now to support that metric. When it went back to NQF's response was, although this looks good, we have so many other metrics that that should take a priority, and unfortunately many of the pediatric issues never do take a priority, and so that's where that one did reside. So I think we could integrate that. I'll put that on my agenda to forward the reliability and validity testing for that to you,
Okay.
so that you can add it to your aggregate.
Would anybody else on the committee like to help? Thank you so much, Dinah.
Ooh. I was just going to ask.
Thank you.
And I'm not volunteering you, Justin, but I realize that we did not assign you to a liaison group.
Oh, you noticed that too? Okay. Yeah, that's fine. I can help.
Oh, thank you for volunteering. All right.
We are a Justin sandwich.
So we'll have a report then in our next meeting. Our next agenda item is update on Trauma Systems Committee Registry Work Group. And I don't know if this is linked to the same discussion that Christie's presenting.
Yes.
Okay.
I think so, for the reports.
So do you want to just default it into
Sure.
Christie's presentation? Okay. So let's move to Christie's presentation then.
Does someone know how to unlock?
Me.
You know that?
matter if I sit here or go to the front, or would you prefer? Does it matter?
Doesn't.
Sam, while she's setting that up, can I just ask one clarification, Sam Vance? All of the conditions in the Model EMS Clinical Guidelines project are all pre-hospital, is that correct?
I don't think he's paying any
He's
attention.
not paying attention to you.
Sam.
Are all the 40 projected topics for the EMS Clinical Guidelines project all pre-hospital based? Or are all 40 of the targeted areas for the EMS, Model EMS Clinical Guidelines project, they're all pre-hospital, correct?
Yes, yes.
Christy, are you ready?
I am. Thanks.
Good, thank you.
Is this on? Can y'all hear me?
Mm-hmm.
Okay. So my name is Christy Metzger, and I'm an epidemiologist, and I'm the acting manager of the Injury Epidemiology and Surveillance Branch. Our previous manager, Tammy Sajak, I know has appeared here before, and she was promoted into a new position elsewhere at DSHS. I'm going to present a couple slides, and then another one of our epidemiologists, Liz Denson, will present a couple more slides. So first, I just wanted to give you the status of where the data are in 2014. This graph shows the number of admissions or discharges by date of admission or month of admission that have been reported to the registry so far this year. It is there's fewer discharges reported more recently than previous, but that's understandable because there is a 90-day reporting period in which the hospitals have 90 days to report discharge from the date of discharge. So this is actually good news because we're just getting more and more data. So we really appreciate everyone who submits the data. And the next time we come here, we'll have more data from the beginning of the year. We know that we're still, even though January all the discharges should be reported already, we know that's not the case. People are still still reporting, and we welcome that. We'd like people to report whenever they can. This is the EMS run data. EMS agencies tend to report on a more frequent basis than hospitals. They have more records, so that makes a lot of sense. The trauma records are about 10% of the EMS records in the registry. So I just wanted to give y'all a couple of updates on data. We have produced multiple state and RAC specific reports for EMS and hospital and pediatrics. If you go to our homepage, and that's www.dshs.state.tx.us/injury, on the very top of that front page, there's a link to updated state summary reports for EMS and hospitals. And if you click there, it will take you to some reports, and I'll show that page in a minute. The other place you can find more data is along the left-hand side. There's a link to data and statistics, and if you click on that link, it'll take you to some more reports. These are the pages that just that give you the links to each of the specific reports for the state and for each RAC. Again, we have summary reports for EMS, for hospital, and also for pediatric hospitalizations. And these reports are, so I'm bringing this up because we'd love your feedback. We've created these reports based on some discussions with stakeholders, but and some of the data that we have. And the summary reports really are the snapshots for the annual data of what we're getting into the registry. We want to produce these annually, and we want your feedback on what should be in it. This, we've taken a stab at what's in it. It'll give you a sense of what kind of data we have, but we want to know what you want to know and how you could use these reports and what you want to have in it and how you would like the data presented. One thing, we have a few reports of special analyses up on our website, but not that many yet. But we do plan to start producing more of these special analyses, which are focused in in-depth analyses of the data. So not the overall, general reports like the summary reports, but something more specific, either topically or focused on specific data elements that y'all would be interested in. Those would be generated more periodically. So I encourage y'all to go to our website and look around and see what we have, see what piques your interest, and let us know feedback. We'd love any kind of feedback you have, either this is great, this isn't so great, this part we really like, this part could be changed. If you have ideas about special analyses that you'd like us to do, let us know. You can send the comments to our general email address, which is injury.web@dshs.state.tx.us. My email is christy.metzger@DSHS, on and on. Or you can talk to any of the epidemiologists as well.
Okay. So just in terms of operationalization, if I give you my email address, you can send this set of slides to me, and then I can disseminate to this group. Our homework will be to review this to the entire PEDS committee
That would be fabulous.
group, and then we will get comments back to you. Correct?
Great.
Now, let me ask you one one operationalization question. Clearly, the big challenge with data is we don't know what we don't know. So
Right.
when we see this data, how will we know that there are other data elements that we would like to see? I mean, if we just put comments of everything we'd like to see, I think the list could be endless, correct?
It could be.
So how do we distill this down to a practical way to review this and give you feedback?
So much of what's in the summary reports are some of the big picture items. And that's really what a summary report is about.
Mm-hmm.
But there could be smaller picture items that could be incorporated into the summary report. For the list of data elements that are available, we have data dictionaries on our website.
Perfect.
I believe it's part, I believe the links are on the left-hand side again. And so you can look there and find out what other data elements are available. As we collect more data and more people submit data, the quality of the reports and the quality of the information we can give back to you improves. So, so that helps as well.
Okay. Now, in terms of long-term access and use, you've heard of several projects that we have ongoing here that clearly the ability to pull outcomes and understand what trends have looked like and where we're moving is going to be important. How do you prioritize requests? What's the difference between the way you manage research questions versus process and project questions?
Right. So if you have a specific data request, let us know what that is. After we clarify with y'all that we have the information that could be helpful to you and it's of a manageable time frame that we can handle, then we will get back to you about for smaller data requests, we hope to be able to produce analyses and get them back to you within 10 days. Obviously, for larger ones, that would take longer or more in-depth analyses. So email us again with your what kind of information that you're looking for and what it's for, and one of our epidemiologists will talk with you about what we can do for you.
And the process is the same for individual report versus a permanent template that we'd like to see. Is that?
Right now, email everything to this website and we'll start prioritizing. You guys, y'all are the consumers of this information. So the more we hear from you, the better job we can do about disseminating this information. That being said, we're only a few of us, so I think there's a lot more stakeholders than there are people to work on it. But we'll make sure to have a priority list and start working through it. So.
Okay. And the last question is there a charge or fee associated with individual projects versus projects that come from this group?
No.
Okay.
And so
one question.
Oh yeah.
In terms of the time frame for the data collection and ultimate reporting, it's on an annual basis. So if I were to have a question that was posed either by the committee or kind of individuals, it would be the last annual data would be 2013. Is that correct, or do you present data all the way up? I mean, you have a 90-day period.
Right.
What's the time frame for that type of information?
Right now, we haven't closed the data set for 2013. We're still receiving data from entities who wish to still report. That process will be ongoing. We don't have any plans right now to close data sets because we're still really working with entities to try to get more data in. In the future, that might be a possibility, but we don't have any set deadline for that. Right now, the reports up there for 2013 are still provisional. They are not final because, again, we haven't closed the data set and we are still getting data for 2013. As the use of our registry gets easier and more straightforward, and our communication, on how to submit the data gets better, then, that time frame to get the data submitted is going to shorten, and then we'll be able to close the data and do final annual reports.
And having said that, how often are these particular reports updated? Is it a daily, monthly, annually? How are they updated?
Right now, these reports have been run once. We will run them again in either late summer or early fall, at which point we think that most of the data for 2013 has come in. So, yeah.
And then lastly, how far back is your data components? How many years back?
So the new registry began in September of 2012.
12.
At which point, a lot of things changed within the registry,
Right.
so a lot of the data changed. So right now, we're really focusing on the more recent data, 2013, and then going forward, which doesn't mean that the old data isn't available, but we're really focusing on more recent data to present information.
So, Christy, I have a question.
Yeah.
For those centers, trauma centers that have collector CV5, currently there's no interface with the state registry.
Oh.
Has that been fixed? Because you're missing all of our data from July 1st of last year when we went with CV5.
Oh, well, I didn't know that, so that's good to know. I'll get back to you. I don't know, so I'll get back to you about that.
So, and I think there's several trauma centers that went to CV5.
Okay.
So you're missing a lot of data for that because there's no interface. There's no way for us to upload, cross-map into the state registry. What our vendor has said is that should be an update or something in July.
Okay.
But the last feedback we got was that that was still in progress.
Okay.
So like for Dell and Cook's on CV5.
Not yet.
Oh.
We will be, so it will affect us soon.
Okay, and
Brack's on CV5, so.
Okay. Well, that's good to know.
EMS providers that have already pushed forward to a higher standard of entities, they can't enter data.
Yeah,
So
I mean, there's a huge disconnect, I think, between what new technology has been provided
Right.
to what can actually go into the Texas registry.
So I didn't get into some of where the registry is going in my little presentation. I just focused on the data. But we are moving toward NTDB and NEMSIS data standards, and those should be pushed out in June and July of this summer. So I'm hoping that might solve some of the issues with data collection from different, using different formats. But I'll check on the CV5. I'm not.
Yeah, I mean,
quite sure
because
about that.
otherwise that data that you just showed is.
Yeah. Well, no, I mean, it definitely is limited
Right.
by what gets submitted to us. There's
Right.
no question about that.
Right.
Yeah. So, if are there any more questions for me? I'll still be here, but Liz, where's Liz? Oh, there she is. She's going to present some of the data that are in the pediatric reports.
Great, thank you.
Hi, I'm Liz.
Liz, what's your last name?
Denson, D-E-N-S-O-N.
Thank you.
Okay, these next few slides is only 4 or 5 of them. Okay, these next 4 or 5 slides are just snapshots of the actual pediatric summary report, the Texas, the overall state report. There are reports for each of the 22 RACs on our website, as Chrissy showed you how to access those. So this would be on the first page of the Texas, the overall state pediatric summary report. And it just gives you a snapshot of the total pediatric hospitalizations, ages 0 to 17, and it highlights trauma team activations, the number of transfers in and out within the RAC to facilities, and you can deduce the number that were transferred out to a facility that's outside of the RAC, and the types of injuries. Traumatic brain injuries and spinal cord injuries are two of the major injuries that we highlight in the trauma registry. Also, you would get overall statistics for in this case, Texas, and in the cases of the RACs that are RAC specific, the number of pediatric hospitalizations that were males, the percentages, Hispanic, and it also highlights falls in motor vehicles, which are two of the largest causes and mechanisms of injury for pediatric patients. 11% of the pediatric traumatic brain injuries were assessed with severe head injuries, and almost 74% of all the pediatric traumatic brain injuries had an injury severity score of 16 or greater. Again, as Christy pointed out, these reports are only as good as the quality of data reported. A lot of the components for these reports are comprised of mandatory fields, but with the entries that may be unknown or not reported, or it's just certain components that you just may not know as a facility at the time of data entry. It kind of alters or skews some of the data in the reports. So if you see your reports for your RACs and the data doesn't look consistent with what you think you submitted or you submitted, you can always call us and we can try to figure out what's going on right there. And as some others have pointed out, some of your data may not have been entered due to limitations in our system.
Liz, before you move forward on that, on your pediatric trauma or traumatic brain injury, I'm going to assume, and please clarify, that is inpatient only?
We just collect inpatient hospitalization and most severe trauma submitted to the registry.
Right, but the state says all traumatic brain, which includes outpatient, so I think that the report, as you report it out, it should be very clear that is inpatient. Because others that we use to support to get assistance will assume that is every traumatic brain injury that's ever existed in the world, and it's not.
Okay, our pediatric summary report has a cover page that specifies by ICD codes, by the hospital inclusion criteria, specifically what cases are reported to the trauma registry. So your cover page is a full page that specifies specifically the types of cases that are submitted to the trauma registry. So it's very clear in our cover page what's included in these reports. And it's the same thing for our EMS reports and our hospital reports. So that's something that we've initiated in recent months to make sure we have a cover page. Even with our individual data requests, they'll have a cover sheet that specifies specifically what types of data are included in the data that we're disseminating. And that's a good point. Thank you for asking that question. Another one of the charts that is going to be in each of the reports, we're looking at the age-sex pyramids for males and female pediatric hospitalizations by age, and it goes from under 1 to 17, and you can see what you usually expect with injuries is that you're going to have more male cases than female cases for most ages. We also include a mechanism injury by intent table to show you that the vast majority of injuries for pediatric cases are unintentional. And that's, in general, most injuries are unintentional. And you can also see the number that were self-inflicted, assaults, undetermined, and the overall totals for the pediatric cases in Texas.
So, Liz, can I ask a quick question? So on drowning submersion, so I understand that there's a drowning submersion registry in the state of Texas that is outside of trauma? So I find that interesting that there were still 93 patients that statewide that put into the trauma registry versus the submersion
We
registry?
still maintain a separate submersion registry, as you pointed out, and we have a separate submersion report, a summary report overall that Erin Cater produces. She creates that. So if you need further in-depth information on drowning and submersions, we have a separate summary report that's currently on our website that specifies statistics and data specific to drownings and submersions. I'm not. Do they match? They're a little different, yes, because they're supposed to be separate registries, but we still get, based on ICD codes, codings that fall into the drowning category in the trauma data set. So they're not mutually exclusive.
Yeah, so why would you include it if you know it's incorrect data?
Yeah.
That's not, that, like I said, it's submitted to us. That's the only thing we can do is code it based on the ICD injury code. And if the hospitals are submitting data that includes drownings, then that's what's going to come up. So I'm only reporting what's in the registry, what the hospitals submit.
Right, but I think the point is that if you know that the data quality is in question because it's reported in a completely separate registry, this can be very misleading.
Yes.
If I were an agency that were looking at funding and I said, oh, submersion's not an issue for you and children because you only have 93 throughout your state, that probably would raise some eyebrows. Does that make sense?
So what you're suggesting is to eliminate drowning and submersions from
To
this table?
eliminate it from this, reference it back to the submersion.
Eliminate, I would send back to that RAC or that facility that they are improperly reporting. Because if you just leave it out, those
Gotcha.
same 93 deaths are not get entered into the submersion registry.
Maybe they are.
Right, yeah.
I mean, that's
but,
the thing. That's what you don't
These are injuries. These aren't deaths. So I got you. Duly noted. So we will look into that, and also I think it may be beneficial to actually pull the records and see if these are additionally being reported to our submersion registry, because those 93 could also be included there. It could be just being reported twice.
And perhaps come to some conclusion that one or the other issue lies. Since all of the patients, whether they are or not, are in this registry, all of the submersions.
right.
Okay, that would be great, and then we can push that information and those suggestions along to the hospitals, because that's a data quality issue.
Yeah.
with what you're
So
reporting.
I would also suggest like poisoning, some of these, even though they might be mechanisms of injury and follow ICD-9 codes, but those don't go in the trauma registry. So a poisoning is an exclusion.
If they meet certain inclusion criteria, if they stay in the facility for 48 hours or more, that they may come into the based on different, depending on the inclusion criteria that they met, they may be coming in under certain other categories because they fall into, we have multiple inclusion criteria, and I'm not sure.
Poisoning's not one of them.
But this is this table is based on framework detailed by the CDC, and you can get more information. This link is also in the report as to the rationale for including all of these mechanisms listed in the table.
So I guess the question, or maybe a clarifying, it would be helpful if you're going to, so if this was just strictly a pediatric registry, that's one thing. But what I heard you say is this is from the pediatric trauma registry?
No,
Or
this is for the trauma registry, and it's just was pulled out by, extracted by age.
So it's from the trauma registry?
It's from the trauma registry.
So that doesn't give you a true reflection of what really is going on, because trauma, poisonings is not a trauma. It's an exclusion criteria that we follow for the NTDB. So
The way that the poisonings end up in here is that if they were reported for another injury that does meet our trauma criteria, and they also had a poisoning that was reported in the ICD-9 codes, that's how they end up.
I think the gestalt of the questions that you're hearing is a concern that data that isn't linked to a definition or a clarification because it resides elsewhere is misleading and will be misused. And if there is a way to identify because where there's alternate sources of the data or where clarification is really required so that someone doesn't misuse it, that would be great. That's not apparent from this.
Well, no, and that's terrific. This is why y'all are the experts.
Yeah.
We know the data, but y'all are the experts on
Yeah.
the content of the data, so we value, these comments.
Okay, so I think we could probably all submit the specifics of that in the mechanism that you've described online. Joe, did you have a?
Yeah, and that's exactly what I was just going to say. This is a snapshot. We've heard over the past year that we want to see some of the outcome from the data, and this is what you're seeing. Now, is there some problems here? Sure there are, but you're only seeing a snapshot. We're not seeing the verbiage up front that explains where this data came from. I think this is a huge step in what I've heard, 11 months ago when I first walked into this room. And to be able to sit here today and say that in 2013, there were 2.5 million PCRs, patient care records, submitted for EMS in the state of Texas, which breaks down to a call every 4.6 seconds or 281 in the last hour in Texas. And then that we transport the whole population of Texas every 10.7 years is a lot farther ahead than we were. As well as I can sit here and say that 46% of the calls are during the daytime, and that 31.5 are from midnight are from 4 o'clock in the afternoon till midnight, or the 22% are after midnight. And you all know that if you looked at the tracking of the data, probably as little as 5 years ago, 9% of your calls were after midnight, 10% somewhere around there. Now we're up to 22%. So that changes your staffing, and it really has an effect on EMS as well as the hospitals. So I think the group has done a great job. Is it perfect? By far not. But I think the whole purpose here today was to show you where we have come and where the possibilities are, where we're going to go.
Yeah, I think it's an excellent framework, and I think this group is particularly poised to be able to give you the kind of feedback that you're looking for, and so we'll make certain that our 3 members who are not here also get the message that they need to give you feedback on that as well.
Okay.
So we get to see copies of all these slides, correct?
Yes.
Yours as well. All right.
Any other questions about this? 'Cause I wrote down all your comments. And thank you. Additionally, another table that you will see, these are just a few of what's actually included in the report. So don't think that the ones I'm showing you is the entire pediatric summary report. We created a table where I pulled the leading injuries, injury categories, to see what are we treating these pediatric patients for in general, like the generalized categories, such as fracture of the upper limb, which would also have more specific codes up under that potential category. And again, there's a link that's included in the report if you need the specific sub categories that fall under these major categories. But for pediatric injury diagnosis in Texas, you have fracture of the limbs, contusions, intracranial injuries, fracture of the skull, and open wounds of the head, neck, and trunk as the 5 leading injury diagnoses.
I think an important part of this particular presentation would be the denominator. Because 5,000 out of 10,000 is very powerful, as opposed to 5,000 out of 2 million.
Oh, so yeah, the total number of hospitalizations is 20,573, but
So
we can make
inclusive.
sure that it's included throughout the report. And that's the snapshot. If you want to see more of the reports, they are on our injury.web website, and they'll also include, for the individual racks, the facilities and the counts of patients that were actually included in the report, so that you can see if your specific entity, your specific hospital, how many records they're actually putting into the system, how many of their records are actually including these reports. And as we stated, they are provisional and will change more than likely the counts depending on any additional submitted records for 2013 that we get submitted. So also please use the injury.web email address to send in your questions, your suggestions, your criticisms, constructive or otherwise. And we'll try to do our best to make the general populace happy, because we can't get everybody's specific preferences in. We're trying to create summary reports that are going to appease the general population, as many people as possible, And then, like Christy pointed out, we will be producing periodic reports that are more topic specific in the future. But we do need your feedback because we're going to need you for us to make these reports make sense. So, thank you.
So Liz and Christy, just one personal note. I've been on this committee for 7 years and 3 years as chair, and a recurrent theme has been a lack of data to be able to drive the things that we're trying to do and to understand outcomes. And this is a huge, huge step. So we thank you very much for not just helping to facilitate the data access, but for being so open to allowing us input to look at what could be templated and what could be done individually. So thank you so much for that.
We have a really good team, so we'll keep plugging away at it. Thanks.
Great. All right, that was our last agenda item.
Question? Yes.
Real quick before you step away, I'm looking at my RAC U, and my trauma center is not listed, and so that's why I'm trying to figure out, like, is there a reason? The 3 rural sites that Krista Spahn has, but the 3 city sites Krista Spahn are not listed.
So we'll work with you to look at that.
Okay.
We have had this issue before and with some other facilities, and it could be something on the interface and getting the data in.
Okay.
Or something to that effect. So we'll look at that. Thanks.
Okay, thanks. We've got 4 minutes before we're scheduled to close. We started 6 minutes late, so we could potentially go up to 6 if we have other public comments, public questions. Anything out there? If not, we will adjourn pretty close to being on time. All right, we are adjourned then. Thank you so much.